Okay, right. Well, good afternoon and good evening, everyone. Thank you very much for your continued interest. Really, going to go through a whole load of cases from our Haempath service over the last couple of weeks. Just to say, next week it'll be breast pathology with Tom Hu from America. So please, as many of you as possible, attend, please. I'll actually be traveling that day, but Lydia will be opening the meeting and hosting it. So for your purposes, you can join as normal. Just to say, I think Lydia has also mentioned in the chat that the recordings have been, all the lectures are being recorded, and she is in the process of uploading them to the Diagnexia YouTube channel. So if you go to the Diagnexia YouTube channel, then you'll be able to see the recordings. We're not completely up to date till the beginning of January so far, but we're working through it, and probably about half the ones are already up. So that'll be a growing resource. Right, so the first one, I thought, we're doing Haempath, and I'm going to take a bit of time over this case because there's a really fascinating case, and it's just come through today, actually. So there's a 73-year-old man who has had a past history of myeloma. So he's got myeloma, and he's had a past history of Merkel cell carcinoma. And he's had a sudden drop in his peripheral blood counts. So query MDS, query recurrent Merkel cell carcinoma, query plasma cell leukemia. Within the peripheral blood, there are circulating blasts. His hemoglobin is 79, white cells 1.8, neutrophils 1, platelets only 16. And so there are some circulating blasts in the peripheral blood. He had a stem cell transplant in 2018, and he's been on lenalidomide maintenance therapy since then. So it's a really informative case. The aspirate's been seen by my colleague, and I'll tell you after we've had a quick look at this what my colleague thought of the aspirate. So get the auto balance and everything correct. I don't know why it's so dirty. I don't know why the scope is so dirty. It's not usually this dirty. Well, it's the slide that's dirty. Okay, so unfortunately, a large part of it is blood clot, but we can ignore that and go into the trephine, which is up here. Yeah, so we've got a large amount of trephine. So for someone born in someone aged 73, it's at least moderately, if not markedly, hypercellular. And got not so much, well, you've got filling in the fat spaces. Paratrabecular fat spaces are lost in places. Other fat spaces are being filled in. And then at higher power, this area here, for instance, there's a sense that there's lots of megakaryocytes here. And then these other irregular medium to large cells scattered all the way through the marrow. Can't see many neutrophils, not much in the way of erythropoiesis either. Then you've got these paler epithelioid-like cells over this area, which we think maybe megakaryocytic, not sure. And there's all these atypical cells. So obviously that clinical history, we're thinking this may be either a plasma cell leukemia or multiple myeloma. Doesn't really look like Merkel cell carcinoma, which is a neuroendocrine carcinoma of the skin. And these don't really look typically like plasma cells. But the thing about myeloma is after treatment in particular, the cells that remain or the cells that recur are often immature, and they can easily look like myeloid cells. So the fact that these don't look like typical plasma cells doesn't exclude the fact that they might be myeloma. Hardly any normal erythropoiesis. So that's what we've got. And it's like that all the way through the marrow. And you can see also here, it's quite interesting because we've got an area of these kind of medium-sized cells, which might be blasts, I'm not sure. Then you've got the intervening paler area with megakaryocytes, possibly megakaryocytes, and then back to that area, and then alternating with this pattern. So even on the H&E, there's a kind of biphasic pattern. So my colleague, Dr. Chasty, he had a look at the aspirate, and he said that the aspirate contained 36% atypical cells, which he thought were plasma cells. So he thought that there was relapsed myeloma based on an infiltrate of atypical plasma cells. So we did some immunos, or we did lots of immunos. I'll start with the first set of immunos we did, if I can find it. Yes, there it is. So the first set of immunos, we thought, right, this is going to be fairly straightforward. We'll look for plasma cells. And the plasma cells will be there. All those atypical cells will be plasma cells, and it'll be myeloma, and that'll be that. So this is the MUM1. It's a nuclear marker for plasma cells. And it's definitely identified the plasma cells. And I think it's identified reactive plasma cells. This is a blood vessel here. And you can see the plasma cells are lining up, certainly along this blood vessel. And I think along here as well. And most of those cells, or no, all those atypical cells, are negative. So we also did CD138. Now, occasionally, myeloma can be negative for CD138, very unusual. I've never come across a case that was negative for MUM1 as well. And here you see, again, there are plasma cells, but they have a reactive distribution along blood vessels. And the other cells, the large cells, are all negative. We did the kappa and lambdas. They didn't show any restriction. We also went on then to do CD56 and CD38. These are, again, CD56 can be positive in atypical plasma cells. Not all atypical plasma cells are positive for it, but some are. And this is the CD38, which is different to CD138. They both have got 38 in their name. And coincidentally, it's another plasma cell marker, and that is also negative in those cells. And CD56 is negative in those cells. Given the fact that we might be dealing with possible Merkel cell carcinoma that has recurred, we did a CAM 5.2, an AE1/A3, and just to cut to the chase, they are also both negative, as were synaptophysin and chromogranin, which are neuroendocrine markers. So this is the CAM 5.2, and the control had worked. We looked for B and T cell markers. They were also negative, apart from in some infiltrating lymphoid cells. So then we went to the myeloid and erythroid markers. So we did glycophorin A, E-cadherin, CD61, CD34, and 117. So this is the and myeloperoxidase. So this is the myeloperoxidase. So it's for myeloid cells. If I can find it. There's, yeah. Where is it? I have to keep looking down the microscope and then going to the screen because the focus isn't the same between the two. So I have to try and find the piece of tissue on the microscope and then move to the screen to focus it for you. So this is myeloperoxidase, and the color balance okay. These cells here are negative. I think there's, myeloperoxidase often got a little bit of background staining, which is, I think, what this is. And these are residual small myeloid cells. So the vast majority of the all these large infiltrating cells are again myeloperoxidase negative. This is glycophorin A, a kind of pan-erythroid marker, and now we're beginning to get somewhere. So this is one of the most complex cases we've had for quite some time, which is why I'm going through it slowly. So we've got variable glycophorin A expression here, and you can see compared to the other things that I've shown you, there's quite a lot of positivity. But again, it's not all cells. And this is really interesting, and it becomes even more prominent on the E-cadherin, which is for more primitive erythroid cells. We can see that there are vascular channels like this here and this here, which are plugged with these cells, which are weakly positive for glycophorin A. And then the areas in between are negative. So we've got this intravascular component, which is positive for glycophorin A, like here. And you can even see here a nice kind of like edge to the vascular space there. So the glycophorin A is, you can see the edge of the vascular space really nicely here. So you've got the vascular spaces plugged with these cells, but the abnormal cells are also present into the interstitium. So we've got abnormal cells in the vascular spaces, which are dilated because they're plugged with these cells, and also in the interstitial spaces. And the E-cadherin, sorry, the glycophorin A, we go to different area. Yeah, maybe, yeah, so this area here. So we've got a mixture of staining for glycophorin A in the vascular channels, which I just showed you, and also in a more interstitial pattern, like in this area here. So it's present in the abnormal cells, both in the vascular channels and also in the interstitial infiltrate. The vascular plugging by tumor cells is shown much more prominently on the E-cadherin. And this is a good example. So here, again, we've got these densely packed vascular spaces, but we've also got positivity in the interstitial areas in between the vascular spaces. In some places, you can see very, very clearly it's the vascular spaces that are positive, but there is some interstitial staining as well. In terms of the percentage positivity, pretty much all of the cells in the vascular spaces are positive at E-cadherin, and also to a lesser degree, but still very high degree for glycophorin A. So you might say, well, that's an erythroid leukemia, but to have erythroid leukemia, you should have at least 80% of the cells are erythroid. We don't have that quite. But interesting, erythroid leukemia does sometimes present with this intrasinusoidal pattern of infiltration, which, to be honest, I've never seen before. I'll just put it up. I've seen a few erythroid leukemias over the years, but I've never seen one with this very prominent intrasinusoidal pattern of growth. It's not exclusively intravascular because it's also present in the interstitium, but it's very strongly intravascular. The confusing bit of this case, not that that wasn't confusing enough, is CD61. So this is for megakaryocytes. And you see we had an impression on the H&E, that there's an increased number of megakaryocytes. And I think that is confirmed here. There's lots of them. But what this also shows is that as the E-cadherin highlighted cells in those vascular spaces, this is highlighting cells in the intervening interstitial areas. So my colleague suggested, well, these could just be, dysplastic megakaryocytes. So there could be a background of erythroleukemia. That's the main diagnosis. And these are just dysplastic megakaryocytes. But I think there's far, far too many of these. Morphologically, they look like blasts. So I think this is actually an acute leukemia showing some erythroid elements and some megakaryocytic elements. It's post chemo because the patients had chemotherapy for both the Merkel cell carcinoma and their mantle cell lymphoma and their myeloma. So it's an acute leukemia that's arisen on the background of chemotherapy. And they often do have dysplastic features in them as well, actually. But this is far, far too many megakaryocytes to be just dysplastic. So a really fascinating case where we've had to, enumerate the blasts, and the plasma cells show no light chain restriction. So there's no myeloma, there's no Merkel cell carcinoma. But instead we have this acute post transplant and post transplant and post chemotherapy, because they've had both of transplant and chemotherapy. Acute myeloid leukemia, and it shows the value of dissecting out the case with different immunos. Going back to the H&E, now we know all that. Would we be able to see that from the H&E? And I think the answer is probably no. Erythroleukemia, well, it doesn't completely fulfill the WHO guidelines for erythroleukemia because in that the cells usually bigger, very large, and so they don't really look like erythroleukemia cells. I suppose the intrasinusoidal is a clue, but very difficult to see on the H&E because everything's all packed in. I think we've got an impression in places that there's an increase in megakaryocytes, but again, difficult to approach on the H&E. On the H&E, myself and my colleagues, despite looking at it, we couldn't really distinguish between a myeloma or an acute leukemia or a carcinoma. Just very, very odd. Anyway, I think it is an acute erythroid leukemia showing some aberrant CD61 expression, and I don't know whether that is reported actually. So I'll just go and see. So yeah, so there was a report in 2021 of a patient with Down syndrome who developed an acute leukemia, as they are prone to do, and it had both erythroid and megakaryocytic differentiation, with a mixed pattern, just as in our case. So it has been reported, but it's not in the WHO. So it's really rare. Okay, that's that case. I think that's taken quite a while, but I think it was worthwhile going through it in a bit of detail because it's definitely exercised our minds. They're not going to do very well, probably. 73, probably relatively frail after all that previous chemotherapy. Um, right, so we've got some MDSs and some chronic myeloid leukemias. So I'll just get the chronic myeloid leukemias out and find one. That's an MDS. Let's CML. Yep, so I'll start with this one. Let's bring up the details. Here. So this is a 74-year-old woman, and she's come in with a high white cell count. So, well, no, she hasn't come in with a high white cell count, actually. Hemoglobin 114, white cells 7.3, so it's not particularly high. Platelets 322. And the aspirate was normal cellular. Right, so let's see what we've got here. So I think it is hypercellular for age. There's also a lot of eosinophilia here. Loads and loads of eosinophils. We have got some scattered erythropoiesis here, these dark cells. So some scattered erythropoiesis, and then lots of immature myeloid cells. But there is maturation to neutrophils. And we have also got megakaryocytes like there, 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 and there. But very, very marked eosinophilia, which is unusual. So lots of eosinophils, increased, very, very markedly increased myelopoiesis. These almost look like plasma cells, but I think they're just very immature kind of promyelocytes and so on. Very marked left shift in the myeloid series. Quite large erythroid islands and very marked increase in cellularity. The patient did have BCR-ABL transcript. So this was chronic phase chronic myeloid leukemia. And I think the fact that there's lots of eosinophilia reflects the fact I think the patient is partially treated before they came to us. And so there's a little bit of differentiation going on as a result down the eosinophilic lineage. And that explains why it's not entirely typical, because you don't usually see this number of eosinophils. We have got another chronic myeloid leukemia, which is maybe a little bit more typical if I can just find it. Not that one. No. Sure there's another one. Sure we had another one. Yeah, this is it. So I'll show you the immunos for that, just to show the degree of myeloid hyperplasia. So you can see marked increase in myelopoiesis. This is myeloperoxidase. And lots of these cells are very densely staining. So the densely staining cells are the more immature cells. The more granular staining ones are more mature cells. Going back to the H&E, there's always a worry with these as to what the blast count is, which is the most important question. You can obviously use CD117 and CD34, but not all blasts are positive for those markers. And so you've got to be careful not just to look at really high power on this, because if you looked at really high power on this and said, well, that looks like a blast, and that looks like a blast, and that looks like a blast, and that, well, suddenly, well over 50% of the cells in this field look like blasts. And that's going to mean it's an acute leukemia. But then if you take a step back, well, there's too much erythroid going on and probably too much maculocytic for it to be an acute leukemia. I don't think it is one. There's too much variation because if you had an acute leukemia like this with this number of blasts, it would just take over and fill the whole thing. There'd be nothing else left. So given the fact that we know it's not an acute leukemia morphologically, and also there's no circulating blasts either, so you can get an early stage of acute leukemia where the blasts haven't started circulating, but it doesn't look or feel like acute leukemia. So that means the cells we started with can't be blasts. So, there's always a danger of thinking, well, looking at high power and thinking, well, that looks a really atypical cell. Well, is there another cell like it? And then another cell like that one, then another cell like that one, and suddenly you're moving up the chain to more mature cells. If it's a blast, it should just stand out distinct from the others. So that one there with the prominent nucleolus, that one there with the prominent nucleolus, and that one there, they may be blasts, but I'm not sure about the rest of them. So the other case of chronic myeloid leukemia, I think, is more typical, and I think this was not treated before it came to us because it arose in our hospital, so there was no pre-treatment. The other one came from Stockport, which is probably about 12 miles away or thereabouts, and the patient's been treated before they got here. This is more typical, with lots and lots of mature neutrophils. So in the other one, there were lots of mature eosinophils. This one, there is a degree of eosinophilia, but less so. But I think what's happened in the other one is they've given it some initial treatment and the immature myeloid cells have gone down an eosinophilic line of differentiation. So that's why we haven't got as many neutrophils in the previous one. Got a lot more neutrophils in this one. Less eosinophilia. Again, you can see lots of background immature myeloid cells like this and this and this. The erythroid is disrupted and it's less than in the other one. Again, that goes in, is concordant with this one having not been treated. And you can see the immature myeloid cells are nicely, densely stacked next to the underlying bone and trabeculae. So this one, and it is also more cellular. So the other one, because it's been partially treated, yes, it was hypercellular, but it wasn't uniformly so. So that was a bit of a clue, I guess. There's still some fat spaces present in this one, the one that's probably received from treatment, compared to this second one, which is prior to any treatment. And neither of them had an increase in blasts. So we signed those out as chronic phase, chronic myeloid leukemia. All right, let's look at this one next, I think. Yeah, another really interesting case showing the value of immunos. So this patient has come from Salford, which is a few miles away, and query myeloma. They're a 67-year-old man. Their hemoglobin is 116, platelets 256, white cells 8.4. They've got not given us a neutrophil count. It's query myeloma, so I suspect they've got a paraprotein, and this is their marrow. They've obviously got some bone changes going on. It's quite a sclerotic bone, lots of cement reversal lines in the bone, so there's obviously new bone formation going on. They're age 67, so not too old in our country, but not young either. And they've definitely got increased an increase in cells, and we don't know what yet, to look at higher power. So they've got an infiltrate of abnormal cells, and this is them. And the question is query myeloma. So monomorphic population of immature cells, and at higher power, we can see that at least some of these cells are plasma cells. So we've got plasma cell, plasma cell, plasma cell, plasma cell, plasma cell, plasma cell. So we've got an increased number of plasma cells, but it also looks like in the background there's an increased number of lymphoid cells. So we just again, there's also lots of mast cells. Okay, there's a mast cell there, and there, and there. Okay. So we look on the we could look on the GEMSA. That'll show us the mast cells nicely. Actually, I don't usually show the GEMSA, but got a nice GEMSA for this one. It's very, very hot in our country at the moment. We haven't had rain for weeks, which is very unusual for us. And in fact, the moors, the mountains, and the hills are going on fire in places. So we're getting, our equivalent of bushfires. So here are the mast cells, and there's definitely increased mast cells showing nicely on the GEMSA. And that's important in the diagnosis, as we'll come to. So we've got what looks to be large numbers of plasma cells. So let's have a look at them by immuno. So if we do MUM1, there's obviously lots of increased plasma cells, which is confirmed, as you would expect, on the CD138. And we thought there was about 20 to 30%, or 25 to 30% involvement by plasma cells based on these two markers. And once it's at that level, of course, you should do the light chain restrictions, but it's going to be restricted. So it was restricted. Can't remember which way round. This is the lambda. Okay, so you can see it has worked. There are one or two positive cells. When the number of cells is this low, you've really got to look at them carefully to make sure it's not just a bit of gunk that's fallen onto the slide, but it is in fact cellular. And on the kappa, it's weak, but you see, probably shows up better on the computer as it does down the scope actually, but there's quite a lot of positive cells. So it's kappa restricted increase in plasma cells. So you could just stop there and say, yep, this is myeloma. That's it. But there's all these other cells in the background which remain unaccounted for. So we went on and did some lymphoid markers. So standard ones, CD3, not much going on. A little bit of a lymphoid aggregate up there, which is intratrabecular, so I'm not going to worry about that. Otherwise, a patchy infiltrate of small T cells. CD20, by contrast, really full. Okay, so lots and lots of CD20 positive cells. Cut long story short, positive for the negative for CD5. This is just a background blush. It's not cellular, it's just all over the place. In fact, it looks nuclear, if anything, which is obviously not correct. There are occasional positive T cells that matches the T cell infiltrate. So we've got a CD5 negative B cell lymphoproliferative disorder with increased B cells positive for 79A and 20. We've also got a proportion of plasma cells which show kappa light chain restriction. So it's considered that this case was considered to most likely be a lymphoplasmacytic lymphoma. And the mast cells are important there because there's often an increase in mast cells in lymphoplasmacytic lymphoma. So if you've got, lymphoplasmacytic lymphoma, you've got limited immunopanel, but you've got a GEMSA and you can see increased mast cells, I think you can make a reasonable assumption that this may be lymphoplasmacytic. It's the one lymphoma where the mast cells really seem to be increased. Unless you're talking about, the systemic mastocytosis, of course, which is a different thing. And in that one, the mast cells will be spindle-shaped largely. So that was an interesting case of what might have been dual pathology, but turned out to be a single pathology. Okay, what's next? Now, the next one is an example of what you can do with very small samples. So never give up. No matter how small the sample is, you can always still say something useful about it. Sometimes it takes a bit more effort to say something useful about something tiny. But, the patient has had a biopsy and you should try and give an answer if you can. So this is the sample. Of course, you have to look at it in context. So this size of sample for diagnosis of myeloma, for instance, or lymphoma, would of course be completely inadequate because it's way, way too small. But this is a patient, a woman, 72 years old. She's got, well, full blood count isn't that bad actually. White cells are low. Sorry, hemoglobin's low, 78. Platelets 215, so that's within normal limits. Neutrophils 0.1, so that's low. And white cells 1.6. So she's got bicytopenia. And she's previously had a diagnosis of myelodysplastic syndrome, stroke myeloproliferative disorder overlap. So this is all we've got. Difficult to assess the cellularity for this age. Difficult to assess anything really. The bones may be a little bit fragmented and thinned. So you could just say, one could say, well, this is too tiny, so I'm not going to bother. I'm just going to say this is too small for diagnostic purposes, and that's all you're getting. But if you look at it at higher power, there's 20 times. We'll move on to the 40 times. It's definitely not normal. So you have to have the caveat in the report that this is a suboptimal sample and may not be entirely representative, but the appearances show. So we've got marked megakaryocytic hyperplasia, loads of megakaryocytes in places forming clusters. We've got slightly scanty and disrupted erythropoiesis, and all the rest of this is left-shifted myelopoiesis, of which there's quite a lot. And there's not much in the way of maturation in the myeloid series. We've got a neutrophil there and there and there, and that's about it. And otherwise, neutrophils are mainly maturing to band forms like that one there, that one there, that one there, and maybe that might be megakaryocyte actually. So we've got a mixture of some dysplastic type features in the myeloid series. So this is definitely an atypical myeloid cell. These will be as well. And also a proliferative element with increased megakaryocytes, even on the H&E. When we look at the immunos, this is myeloperoxidase. I can find it. It always hides when it's so small. Yeah. So myeloperoxidase is in fact reduced, I'd say, compared to normal. But it is left shifted and it's abnormal. Remember, the other ones we've seen has had more of a mixture of these very darkly staining cells, more of a mixture of these very darkly staining cells, and the more granular maturing cells. So these are the kind of granular maturing ones. These are very dark ones. But this here, most of these cells look very dark. So it is left shifted. And we know from the H&E there was poor myeloid maturation. Ecadherin shows the erythroid nicely. That's control. And find the tissue, circle around, try and eventually might have to actually give up and look for it. There it is. So a reasonable amount of erythropoiesis actually. Pretty good. But we've got lots of isolated cells off on their own, a bit discohesive. So again, that's a dysplastic feature. And then the megakaryocytes are really massively increased in this case. There's absolutely tons of them. So really, really increased megakaryopoiesis. Lots and lots of clusters, immature cells, atypical cells, and lots of small micromegakaryocytes like that one there. And these two down here, I'm just going to higher power. Yeah, so lots of micromegakaryocytes as well, like that there, that there. So it looks dysplastic, but it's also got this increased number of megakaryocytes, which is kind of like a proliferative feature. So overall, this was considered to be ongoing multilineage dysplasia in a background of myelodysplastic stroke myeloproliferative overlap syndrome. The blast count was just 3%, we thought. And CD34, I think, showed that nicely. Yeah. So you can see here, it's definitely increased blasts there, 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 there. Often just this kind of like dot-like positivity on the edge of the cell is what you get with CD34. But, in a normal marrow, you shouldn't get any or no more than one or two blasts. And here we've got lots just in this field. So that was reported as myelodysplastic myeloproliferative overlap syndrome and shows how much you can do with just one tiny section. Now, in that case, we did have a history that she's had a history of that going back. So really, we were just looking to see, has it got worse or not? It probably would not be appropriate to make a primary diagnosis on that amount of material. But given the fact that she was, she was being followed up, there's a clear history behind, then I think it was okay to say, but with the caveat that it might not be representative. Oh, excuse me. It's been a very long week already, and it's only Wednesday. And going to Edinburgh tomorrow, and then back to Manchester for Friday. So I'm all over the place this week. So the next one, I'll just finish with this next one. Is a male, 72. So they've all been about the same age. The youngest was 62, I think. This person has had mild dysplasia since May 2022. But then this transformed into AML, secondary to mild dysplasia, in October of that year. He had a reduced intensity stem cell transplant in July 2023, and his AML relapsed in March this year. And now this is after azacitidine treatment. So it's a bit of a scrappy biopsy, particularly when people are older. They've often got crumbly bones, so it doesn't come out nicely. It just comes out in a bit of a fragmented mess, which can make interpretation of the cellularity more difficult and the architecture more difficult. Makes interpretation of the bones easier because obviously they're just fragmented. A lot of bone dust at this end. So not particularly cellular. And again, not an awful amount of material to work with. So this is interesting because this has got a mixture of some regenerative features, some post-chemotherapy change with some hemosiderin here, and also residual blasts. So after chemotherapy for acute myeloid leukemia, you may often get a mix of regenerating features overall, but then the blasts also being either persistent or coming back. So we've got, very variable morphology, got some erythroid cells, some lymphoid cells, sorry, not lymphoid cells, some erythroid cells, the myeloid cells, got megakaryocytes. So superficially, it looks like this is just regenerating nicely, actually. But there are also a population of cells that look a bit more uniform and a bit more worrying, some of them quite large. It's the same all the way through the biopsy, which is actually quite a small biopsy, actually. That's kind of like we've seen it, most of it now. And on the immunos, this is myeloperoxidase. So you've got a very marked increase in myelopoiesis, which is probably a combination of some residual disease plus regeneration post-chemotherapy. Ecadherin for erythroid, actually really low. Yeah, so hardly any erythropoiesis. And this is really worrying because this means that there isn't really all that much regeneration going on. So what we're seeing in the myeloid is more likely to be MDS stroke AML, because when in regeneration, the erythroid always regenerates quite rapidly and is often the first to be seen in a marrow. So the fact we've got such little erythroid regeneration means that the myeloid population is more likely to be neoplastic than regenerative. CD61, again, very little, very little. And in some of these cases, if it's an if it's an MDS which is then transformed to AML, the blast component may be removed by chemotherapy, but the underlying dysplastic process from the myelodysplasia may remain. Of course, this patient has had a donor stem cell transplant, which means that their initial disease in terms of an MDS probably isn't there anymore. So if something comes back, it's probably an acute leukemia. Got to be careful when you think about transplants. Have they had an autograft? Because if you've got an autograft, there's much more chance of the initial host disease coming back compared to a donor transplant. But the thing that clinched it in this case was, I think, the CD34. And you got to look at it carefully because it's always weak. You can see here there's lots of cells positive for CD34. Putting everything together, it was considered that though these account for less than 20% of the cells present, they were probably about 15% of the cells overall. They were considered to be residual acute leukemia. Now, this is 100 days after this was just a month after he started azacitidine, so they might just decide just to increase the cycles and see if it goes down, or they might switch to another treatment. They certainly reduced it compared to presentation, but there's still some residual acute leukemia. Okay, I have another meeting to go to in a few minutes. I'll be a couple of minutes late for it, so I'll just stop there. Are there any questions from anyone? And again, if we could just have a show of hands whether this new format is still working well for you or not. If you just put it in, I don't know how you put it in, maybe in the chat or something. People just like put a thumbs up or yes. I see that Lydia's very kindly put up the YouTube site, so you'll be able to see. We're recording both the external speakers and the Haempath sessions from now on. So I hope that these sessions are proving useful in this new format. Don't feel shy about asking questions. Just put your hand up, and Lydia, I'm busy doing other things, so I don't really keep an eye on the chat. But Lydia is doing so very kindly, and she'll see and let anyone
Absolutely.
say something.
Even if people don't want to say it out loud, they can still put questions into the chat, and I'm happy to read them out to Richard as well. So
yeah. So just checking this. If anyone could give us a positive or a negative or anything about the new format, that would be much appreciated. Is there anything coming through? I'm looking at the chat, I can't see it.
oh, there's a great lecture format, good from.
Oh, okay. I can't see it. I don't know why I can't see it.
Oh, can you not see the Q&A?
No.
Oh, okay. I'll look into that. Yeah, Wangari Camus said great lecture format.
Okay. That's good because I'm very much guided by what people need, want, and find useful. So thank you very much. So next week is going to be Dr. Tom Hu talking about breast cancer. And after that, I'm actually traveling for a couple of weeks. So I'm going to come up with a program with Lydia that we can share, that there will be still access to material while I'm away. We do have a bank of recordings from the Pathological Society Winter School. I know that a couple of you may have attended that, but we can certainly make that material available. We have permission to do so that we can continue the program even while I'm traveling. And I may be in areas where I don't actually have access to the internet for just a couple of weeks. But I look forward to seeing you all next week. Lydia will be holding the fort and manning it. Otherwise, I hope you all have a very nice afternoon and evening wherever you are. Thank you very much.